Assalamu alaikum, and thank you all for your coming and attending our seventh Journal Club PDEM. And I would really be thankful for Dr. Sufyan in accepting our invitation. So Dr. Sufyan is a consultant in pediatric emergency at Royal Hospital in Muscat, Oman, and a digital leader contributing to national transformation initiatives. He completed his emergency medicine residency and pediatric emergency medicine fellowship at McGill. And by that, he holds a diploma in health informatics at McMaster, and he has a dual board certified in American Board Emergency Medicine and the Royal College of Physicians Surgeons in Canada, blending the frontline resuscitation with health informatics and his interests including digital innovation, medical education, and simulation-based training. And he is here with us to take us through what's new in pediatric resuscitation 2025. So, Dr. Sufyan, the floor is yours.
شكرا جزيلا دكتورة Yara. I'm really flattered with this introduction. I would like to thank you and the organizing committee on this group. I'm very excited to see a lot of people interested in pediatric emergency. I see the crowd in the session. I'm very, very happy about that. So without any further ado, let's get into it. I was given the task to give a talk about what's the latest update in the AHA guidelines 2025. And just to, I don't want to bummer my presentation, but actually there is not much of an update in 2025. But what we'll try to do is basically we'll go through the minor changes that happen in the latest guidelines, and we'll deep dive into the guideline itself. As a start, I don't actually have any disclosure to make. The objective of this talk basically will give you an overview about pediatric cardiac arrest, trends and survival data a little bit, and then we'll understand how the guidelines ecosystem actually work, and then we'll deep dive into the 2025 pediatric BLS and PALS updates. I left the neonatal updates because it required by itself another session. I will leave it for another volunteer to take it, but today we'll focus mainly in basic and advanced pediatric resuscitation. Just to give you some numbers and why this is very important, pediatric cardiac arrest is not that uncommon. It's actually, statistics shows that in the United States annually, there is more than 20,000 cardiac arrests inside hospitals, compared to more than 7,000 cardiac arrests outside the hospital in pediatric population. So it's something not that uncommon. The good thing is happening that over the years, over the last 2 decades, we are doing better. The outcome, the survival from the pediatric cardiac arrest is actually improving. We doubled the survival in the last 2 decades. And this goes down to early recognition, high quality CPR, and improvement in the post-cardiac care and the increased utilization of ECMO. And if you look at the outcome of a cardiac arrest outside the hospital, it actually differs, and it's really related to the age of the child. Neonatal, in the neonatal period, or kids under the 1 year of age, they have a poor outcome. It goes down to 6% of survival, compared to that to adolescent kids, and their survivors of cardiac arrest outside the hospital is up to 17%. So it really varies based on the age. And this comes down to the etiology of these cardiac arrests. Interesting thing that we need to discuss, kids are not small adults, because the cardiac arrest in pediatric population is completely different than the cardiac arrest that happen in the adult world. In the pediatric population, mostly the cardiac arrest is following a respiratory hypoxia. So most of those kids actually go into a hypoxia phase and then end up leading to bradycardia, hypotension, and then it leads to cardiac arrest. Compare this to the adult side, where there is an increased prevalence of ischemic heart disease. Their cardiac arrest mostly secondary to a ischemic cardiac disease. So looking at the origin or the underlying pathology of cardiac arrest is important, because it will give you a clue about what kind of rhythm you are expecting. In pediatric population, most of the time what we face is non-shockable rhythms like PA or asystole, because it's a respiratory nature, hypoxia nature. Compared to that to the adult population, They are mostly their cardiac arrest is a shockable rhythm, either a pulseless VTAC or a ventricular fibrillation. Looking at two different and distinct pathologies and rhythms on cardiac arrest, there is something that very different in these two populations. In the adult population, if you increase AED utilization and spread EED utilization in the community, there will be a population level improvement in cardiac arrest because AED makes a big change, a big difference in the outcome of a cardiac arrest. But that does not happen in pediatric population. Why? Because most of those arrests are PEA or a asystole, which are non-shockable rhythms. So even if we increase teaching the community about how they use AED, if you spread AED everywhere in the schools, in the malls, and everywhere, still the outcome of pediatric population will not improve at the population level because of the origin and the rhythm of these cardiac arrests. So this is a quick trivia. If you want to know what is the best city if you have to have a cardiac arrest, is actually Las Vegas. Why? Because Las Vegas, they spend a lot of money in educating people, communities. It's full of casinos, and in the casinos, it's mandated to have an AED in all these casinos, as well as they actually taught the people working on these casinos to do a basic life support for any cardiac arrest. So if you are in Las Vegas, the chances of survival is very high because there is a lot of AED and there is a lot of community education about how to do a proper CPR. The outcome of a cardiac arrest out of the hospital in Las Vegas is up to 70% survival. And the time to the first defibrillation is very, very short because it's widely available everywhere. So if you want to have a cardiac arrest, it's better be in Las Vegas. So let's change gear and talk about systems of care. And we'll start with the chain of survival. I think most of you are aware about the chain of survival. When I started my career, we were only focusing on four chains. The one in the middles, however, over the years, the chain has expanded from four chains to now up to six chains. And why exactly this is happening? Because with time, we started to realize that there is not much of a improvement in the outcome of whether pediatric or adult cardiac arrest. In general, we did so good in terms of high quality CPR, advancement in resuscitation, and advancement in post cardiac arrest care, and that improve our cardiac arrest outcome. However, we plateaued a little bit, and then we started to realize, maybe we should actually act before cardiac arrest happen, and we realized prevention is a key. So we added that prevention chain in the front. So we started to also think about how we can prevent cardiac arrest. Also, on the other hand, because we became so good in resuscitation, there are so many survivors of cardiac arrest, and we realize that those survivors need special care. We need their recovery journey is long, and we need to take care of them. So we added a recovery chain. That's why now we have a six chain of survival, starting from four in the past, and now we are six. And this did not change compared to 2020. We still had this in 2020. This is just a reaffirmment of the survival chain. But the specific thing that happened in 2025, we only have one chain for all, pediatric, adult, and in unit. In the past, in the 2020, we have a different chains for every population. Like adult, they have their own chain. Pediatric, they have their own chain. And neonatal, they have their own chain. Slight variation is there. But in this version, we only have one chain of survival for adult, pediatric, and in units. So focusing on prevention first, there are many things that we can do to improve the outcome of cardiac arrest and to prevent cardiac arrest from happening. If you look at the out of hospital cardiac arrest, safety initiatives and education of the population is a key. So things like bike helmets loads, our increased awareness of sudden infant death, and also water safety and pool safety. All these will prevent cardiac arrest from happening. Also to empower layman people and educate them about how to do a proper CPR, what to do if somebody is choking. This education and awareness decrease cardiac arrest in out of hospital field. And finally, increase recognition and access to the care. So we educate parent about how to recognize a sick child, to seek medical attention promptly, and this will prevent cardiac arrest of happening outside the hospital. Looking at the in-hospital cardiac arrest, we can improve cardiac arrest by identify high-risk patients. We know by now, like those pediatric cardiac patients are actually at higher risk. Those patients with myocarditis, those patients with a heart failure, those patients are at high risk of cardiac arrest. So we focus on those patients during admission. We put them in a specific units with a continuous monitoring. They are in a high dependency or a critical care units, so they are monitored continuously. We also implement systems to pick up those high risk patients. In my hospital, I work at Royal Hospital. We utilize PEWS, which is the Pediatric Early Warning Score, to identify those patients with the high PEWS. We identify them as risky patients. So if a patient has a very high PEWS score, we admit them to a high dependency automatically. So we have a close eye on those patients and we prevent cardiac arrest from happening. And finally, we also, even if cardiac arrest happen in the hospital, we know those patients post-cardiac arrest are very fragile and they can go into another cardiac arrest. So we also focus on those patients and we aggressively treat the post-cardiac arrest syndrome. Like we prevent hypoxia, we prevent hypotension, and we manage them to prevent further deterioration and going to a second cardiac arrest. All these preventions help us to decrease cardiac arrest either out of the hospital or in hospital. I don't actually have, I have only one screen, so I don't actually see the chat. If you guys have a question or something that you cannot wait till the end of the presentation, feel free to interrupt me. Moving on, we'll talk about the formula of survival. So knowing new things in literature, doing research, and science does not translate to better outcome immediately. We cannot just figure out something by papers and doing studies and we assume that the outcome or the survivor will change. There is an interconnected processes that need to happen at the same time so that we bring what we learn and what we achieve by research to the bedside and achieve improvement in the outcome and survival. It's called the formula of survival. We need science. We need to do studies. We need to reevaluate our research. And then we bring this science into education. No, it's not enough only to figure out that, okay, good quality CPR is actually improving outcome. No, we need actually to teach our physicians, to teach all those taking care of patients how to do an effective CPR. So prompt education is a key. Sorry. And finally, even if you teach everybody how to do a proper CPR, if you did not implement systems, then this change will not happen, and this change will not be sustainable. So implementation and execution is very important. So all these together will lead to improvement in the outcome. And the chain of survival is only as strong as its weakest point. So if you have a weak implementation, your survival will not improve. You have to make sure all these chains, all these aspects are strong and solid to drive change. Okay. So if you have ever read, one second. Sorry. So if you have ever read the guidelines of AHA, you will always hear the term LCOR. LCOR is an organization. It's an international organization. It's a non-profit organization. What it does is unite all major resuscitation councils. So it has a membership of all from people from AHA, people from the European Resuscitation Council, expert in the field from pediatric, adult, NICU, ICU, and everybody who is involved in the research and literature and have a direct impact on the science of resuscitation have membership in the LCOR. And what do they do basically? They perform a continuous systemic evidence reviews. They don't they don't publish guidelines, but they only review whatever is available out there, and then they release something called the consensus on science with treatment and recommendation. Basically, they have a question, and then they give you the evidence behind the question. For example, does the intervention X improve survival compared to Y? They don't release guidelines, they just release consensus on intervention. Then what happened is, once ELCOR published this consensus, organization like AHA and the European Resuscitation Council, they released the guidelines. Sorry, guys. Give me a moment. Okay, so the bodies like AHA and the European Resuscitation Council, they publish the guidelines. No, now these are the organization where they are responsible of certification, training, implementation of the guidelines. And there are multiple uh, organizations like that. So in the North America and the Middle East region, we follow AHA. In Europe, they follow the European Resuscitation Council. Each of these guidelines are extrapolated from the LCOR recommendation. However, the implementation, the wording, the recommendation might slightly be different. For example, if you look at the AHA guideline, it's always focused in training infrastructure and algorithms. However, if you look at the European guidelines, it's mainly driven by physiology. So there's minor changes in the guidelines, but overall, because they all depend on the LCOR recommendation, they are very similar. And also you need to understand, when you read the guidelines, you need to understand what do they mean. Because when they release a recommendation or a guideline, they always follow it by the how strong is the class of that recommendation and what was the level of evidence. The class of recommendation, it basically tells you the strength of that recommendation. Are we forcefully, is this a beneficial recommendation? Is it something moderate? It's not that strong. We are not strongly recommending it. We don't know if we are not sure if it is good or bad, or no, we are 100% sure it's harm and you should not do it. That's how they phrase their recommendation, but it's always followed by the level of evidence. How sure we are. Where did we get these recommendations? Based on what kind of evidence? And the evidence is depending on the type of studies. So if you have a high quality studies, a randomized controlled studies of a high quality, or if you have a meta-analysis, then this is a level of evidence A. And then you go down and the lowest level of evidence is then just an expert opinion. And this makes a major challenge in the guidelines. If you look at the studies of cardiac arrest is one of the major events that happen. It's also have a lot of impact and sequelae on the community. We are losing life. So lots of money is driven into resuscitation research. However, unfortunately, the research that come out of cardiac arrest is always limited. You cannot do an RCT in a cardiac arrest patient with a cardiac arrest. The outcome analysis of cardiac arrest can be very variable. If you look at the studies, some of the study focus on survival within 24 hours. Some of the studies focus on survival in 30 days. Some of the studies focus on survival on hospital discharge, but others focus on neurological outcome. So the outcome is it varies between studies, and that gives us very heterogenic studies that we cannot combine them together to get a solid evidence. So we are very limited with this research and data in cardiac arrest. And if you look at our 2025 AHA guideline, they actually tells you they released around 760 recommendation. And if you look at the evidence of this recommendation, only 1% of the recommendation are level A recommendation. Like the level of evidence is level A. Look at this. If you look at the 700, 1% of the 700 is 7. And we are talking about the whole guideline recommendation, pediatric, adult, and unit. Only 7 recommendations were based on a high level evidence. The rest of those recommendations, mainly if you look at those, 27% is just level C, expert opinion. If you look at the rest is level C limited data, and it's around 38% of these recommendations. So in short, we have limited data, and the recommendation are not based on a very solid evidence, because we have just basically a limited data and research in the cardiac arrest outcome. So let's shift gear and we talk about the what's new in pediatric basic life support. We start with airway and mainly the severe foreign body airway obstruction. Here's a slight change that happened. Number one is the 5 and 5 sequence. I think some of the people, including myself, when I read the update, when they said, oh, the recommendation now is you do the 5 blows in the back and then 5 abdominal thrust. I was like confused, but this is what we used to do in 2020. There's no change. The change is in the wording. In 2020, they did not specify what was the sequence. Should we do the abdominal thrust first, or you should do the back blows first? But now we have an emerging evidence that says the back blows are more effective than the abdominal thrust. So in this guideline in 2025, they recommended to start with the back blows first and then followed by a 5 abdominal thrust. And if you are dealing with an infant, you cannot do abdominal thrust because it can be harmful. So they replaced that with a 5 chest thrust. Again, this is not something new. It's just the sequence is new. What's really, really new here, they recommend doing also a chest thrust using the heel of the hand. Again, this is not something new. What's new basically is how you do a CPR. We'll see it in the next slide. Also, if you look at the guidelines, they mention something called the portable suction devices. I don't know if you guys saw this in the news or a YouTube video. There is a YouTube video about a guy who was in a restaurant, suddenly faced a child choking had a food impaction, and he ran outside the whole restaurant, opened the trunk of his car, and he bring this device and he used it in the child to remove the foreign body, and it was like in the news, and the guidelines actually talked about this. They don't know if these devices are helpful. The data is very limited. There's only one study driven by the company that made the device. The device is basically like a suction cup. You put it in the patient's mouth and nose, and then you just suction it, and then hopefully the foreign body goes out. Unfortunately, there is very limited data to support the use of these devices. However, nothing against them. So it was phrased in the guideline as it's a reasonable thing to do, but the data is very limited. Moving on, and we talk about airway and breathing. Again, we are in the airway and breathing, nothing much changed there. We are still we'll stick with the head tilt and chin lift. And if your patient is suspected to have a cervical injury, then you should not move the head. So instead of doing the head tilt chin lift technique, you use the jaw thrust. And they explicitly say if you are having difficulty doing the jaw thrust in a traumatic patient, then you are allowed to do the head tilt technique, head tilt and chin lift technique, because basically airway compromise is fatal, and if you cannot, and that is a priority compared to the cervical injury. Rescue breath is exactly the same, 1 breath every 2 to 3 seconds, and avoid excessive ventilation. They also mentioned the layman rescuer decision in terms of ventilation. Many people are hesitant to give mouth-to-mouth breath during CPR. So they allowed it in the guidelines, saying if the rescuer, a layman rescuer, hesitated about giving mouth-to-mouth breath, then it's okay to do a compression-only CPR without doing a breath. So basically just compression without breaths. This is only allowed if you are not a healthcare professional. So everybody in this Zoom meeting should not do it. It's not allowed for you to do that. But for layman rescuer, they are allowed, because either they do a compression only CPR or they don't do CPR. So they allow them to do compression only CPR. However, keep in mind, we know that conventional CPR, which is breaths and chest compression than breath and chest compression is actually important. It's superior to compression only CPR. The no pulse decision, again, these are a very fine wording of the guidelines. I hope that I'm shining light on those because for me, I found this topic is a bit basic and everybody can read it. However, when I discuss it with my resident recently, I figure out that a lot of people actually missed what's between the lines. And so it's a good refresher for everybody. What do we mean about no pulse decision? So if you look at the sequence of identification of a cardiac arrest in PALS and BLS, you start with looking for signs of life, and these are three. One, if there is any movement, so you check any responsiveness, and then you check if there is any breathing effort, and finally check if there is a pulse or not. If you are a layman person, a layman rescuer, then you should not waste time in pulse check. What you need to do is you identify is there a responsiveness and if there is a breathing effort. If none of those are there, then you consider this is a patient in a cardiac arrest. And you initially start with the chest compression immediately. If you are a healthcare worker, then you are giving 10 seconds window to check for a pulse. So check for a pulse either in the brachial artery if you are dealing with an infant, or the carotid or the femoral if you are dealing with a bigger child. And you only have 10 seconds. If you are not sure if you felt a pulse or not, then you immediately proceed with the chest compression and your resuscitation. And why is that actually? Because there are studies that looked into this, and what they found there's a lot of hesitation and difficulty in palpating the pulse, and that lead to a delay in initiation compression. So that's why they give you a limited time, and they also remove that hassle from a layman rescuer. Moving on into the sequence. Should we do CAB, compression airway breathing, or we should do an ABC? Okay. If you look at I spoke already in the previous slide that cardiac arrest in pediatric population is mainly hypoxia. Those children goes into hypoxia initially, bradycardia, hypotension, then they collapse. So intuitively, we think it's better. Physiologically, we think it's better to do breathing first because those patients were actually hypoxic for a very long time and then they went into a cardiac arrest. That makes more sense. However, the recommendation is still with a CAB. Why? Because the CAB is recommended in the adult population, and for simplicity and making the guideline consistent and the training consistent, so we stick with the CAB sequence. So compression first, and then you give a breath. They also looked at this in studies, and they looked at if you start with the compression and then you give the breath after the 30 compression or the 15 compression, how long is that delay? And then they look at the study, and the delay was not that much. The delay was around 5 seconds. So if you see a cardiac arrest and then you immediately start with the compression, 15 to 2 breath, that takes 5 seconds only versus you start with a breath and then you do a compression. So when they weigh the benefit and the risk, the benefit is basically consistency. You do have the same training for adult pediatric and you do the CAB approach versus the risk, which is a delay around 5 seconds. They go with the consistency for the education purposes and training purposes. So we stick with our CAB, compression airway breathing. Moving on the technique of the compression, here is a new change happening in 2025. If you have a child more than 1 year, we are still the same. We are doing a compression with either one hand or two hands. It depends if you feel comfortable and you are able to compress with one hand and the child is small habits, then you can do with a one hand. If you cannot do that, you can do with two hands on top of each other. And the depth is 1/3 of the chest wall. Now, in the infant less than 1 year, the preferred method is you encirculate the body of the baby with two hands and then you put the two thumbs together side by side, and you compress on the lower sternum. However, we used also to have the two-finger technique. You put two fingers in the lower sternum and you do a compression like that. That was out of favor now. It's out of the guideline. You should not do it. You either stick with a two thumb encirculating the infant, and if the infant is too big or your hands are too small and you cannot encirculate the body of the infant, then you are allowed to do one hand compression like a child. But there is no room for a two-finger technique anymore. It's out of the guidelines and you should not do it. The main reason was the studies showed that the two-finger technique always lead to a very minimal compression, or like a depth of the compression. That's why it was removed from the guideline last year. Moving on in the quality of the CPR, we are still the same. Nothing much is there except the targets. Number one, what are the high quality CPR features? You need to do it fast, but not too fast, at a rate of 100 to 120. You should have a good depth, which is 1/3 of the AP diameter of the chest wall. And then finally, you have to minimize interruption, and you have to achieve CCP, which is a chest compression fraction of more than 60%, and ideally more than 80% if doing an excellent CPR. There are ways you can monitor how good is your CPR or compressions. One, if you, the utilization of the capnography. If your capnography shows end-tidal CO2 less than 10 millimercury, you are not doing a good job. You have to ask your compression to do a better compression. Swap the compressor. Find somebody who's doing a better compressions. If you are doing, if the end-tidal CO2 is showing above 20 millimercury, that's an effective CPR. That's an effective compression, and you should continue it. If the death or the cardiac arrest happened in an intensive care unit and the child had an arterial line at that moment, then you can utilize that arterial line to help you and guide you in your compression quality. And how do you do that? You look at the diastolic blood pressure. In the infant, you aim for a diastolic blood pressure more than 25 millimercury. In children more than 1 year, you aim of a diastolic blood pressure more than 30 millimercury. So this is a new added to the 2025 guidelines. It was not, the targets were not there in the previous guidelines. Does that make a big difference? Personally, no. I work in emergency room. The majority of you work in emergency room. I don't think we have an arterial line on those patients, but this is more feasible in the context of critical care and ICU setup. Another interesting thing that mentioned in the guideline is the utilization of the backboard. Some of the things in the guidelines, sometimes you feel they're too much, but then if you look at the evidence and the data behind them, you realize they are actually very important. One of them, the backboard. Sometimes I feel frustrated when I see somebody who's like bringing the backboard, and we are doing compressions, but realizing that without backboard, your compression is not effective because the mattress, and usually most of the patients are actually on the bed of the hospital, the mattress absorb much of your compression, up to 57% of the force of the compression. So you are not doing a good compression. So the backboard are really important in the CPR, and you should actually bring those during the CPR. Looking at the defibrillation, not much is changed there. It's just an emphasis on the early defibrillation. So in the context of shockable rhythm, you have to shock as soon as possible, and you try to minimize the peri-shock pauses. So as soon as possible, put the pads while you are doing compression and charge while you are doing compression, and only remove your hand when you are delivering the shock. There are data and some studies done on the adult population trying to see if you have multiple shocks sequentially, maybe that will be better than delivering one shock. So dual sequential defibrillation and multiple shock in a row without doing compression, that was tried in the adult population, but that did not lead to any improving in the outcome. So in this guideline, they affirm again that it's only single shock, and then you proceed with your compression. No, there is no room for dual shocks or a sequential shock in the shockable rhythm. And also they talked about biphasic and monophasic defibrillators. Most of hospitals now use biphasic defibrillators, and it's actually better because it deliver a smaller amount of energy and have a lesser side effects. But if you don't have those, you are still okay to go with the monophasic defibrillators. And then they talked about the manual versus an automated defibrillation. As a healthcare professional, you should not use the AED. You should always use the manual defibrillator. The AED basically identify the rhythm, analyze the rhythm by itself, and identify the need for a shock by itself. The machine does the rhythm analysis, and the machine deliver a fixed dose of shock. It doesn't go with the weight-based shock, and it doesn't it takes time. So that's why they encourage to use a manual defibrillator for healthcare professionals. For layman people and EMS personnel, probably it's wise to use an AED. And there are studies compare the two. What they found that there is so much delay with the AED utilization. However, when you use the manual defibrillator, unfortunately, many of the physicians have difficulty identifying the rhythm, and they tend to shock unshockable rhythm. So the question is it harmful? We don't really know. If you shock a systole or a PEA, is that harmful for the patient because he's already dead? We don't know. But we know it's not beneficial for a patient to, in non-shockable rhythm, to deliver a shock. So it's not useful. Is it harmful? We don't know. But for sure, it will delay you because you are giving unnecessarily shock instead of doing a high quality CPR. And we know high quality CPR is the best thing you can do to a patient in a cardiac arrest. Pad selections. If you have an attenuator for the paddles, then you should use them. If you don't, then you proceed with the adult pads and you shock them with the adult pads or the paddles. In terms of the placement of these pads, you have the choice. If you are able to apply the pads where they don't touch each other, then you are okay to go with anterolateral. But if the child is too small and they are overlapping, then you go with the anterior posterior placement of the pads. In terms of suspected opioid overdose, standard resuscitation is you always focus on ventilation and CPR, even if the patient was dying from an overdose of opioids, because that takes priority while you're preparing your antidote. Always compressions, always ventilation takes priority in the context of opioid overdose, a suspected opioid overdose. Naloxone is a very important, and antidote also is important, but does not take the priority of compression or ventilation. This is also an update from the previous guidelines, but it's a minor update where they actually placed it within the guidelines themselves, BLS and the PALS guidelines. In the previous guidelines in 2020, it was under circumstances or another documents. So they just moved it into the PALS or BLS documents. So quick refresher for you guys to compare 2020 versus 2025. The major changes there, the sequence of foreign body, severe foreign body is instead of just doing whatever you want, now they explicitly advise you to start with back growth because it is more effective than the abdominal thrust. Infant compression, we are not allowed to use two fingers compression. We stick to one hand or encirculating the body of the infant with the two thumbs compressing the lower sternum. And the opioid guidance is mentioned within the BLS and PALS, and it was in the past by its own documents. Moving on to the pediatric advanced life support. We start with airway strategy. Again, ventilation is a priority. If you can ventilate a patient with either a bag mask valve or you have a supraglottic airway, then you stick with it. You don't need to intubate. A lot of people are enthusiastic about intubation. Residents wants to intubate, but people in the ICU always love intubation. But if you are able to ventilate using a bag mask valve, then you stick with it. No need to waste time. No need to interrupt your CPR for an intubation. Another dilemma is, should you use a cuffed tube versus uncuffed tube? Lots of pediatrician loves the uncuffed tube. I'm a background of an adult emergency training. I love the cuffed tubes, and the recommendation prefer the cuffed tube a little bit, but they don't say whether you should one over the other. There is still room for uncuffed tube, but there is an advantage of the cuffed tubes, which are basically you have a better seal and you are able to, it eliminates the need to replace the ET tube, because if you have a uncuffed tube and they have a lot of leaks, so you'll have to re-intubate the patient again if you could not ventilate him with using a small ET tube. If you have a cuffed tube, you can just inflate the tube or deflate the tube. But if you have an uncuffed tube, you are struggling now with the ventilation, you have to replace the tube, and that will lead to another interruption of the CPR and bad outcome. Moving on the intubation technique, the cricoid pressure was always not recommended in this guideline because its routine application can hinder the airway, can obstruct the airway, and also can also make your visualization of the airway difficult. So it's no longer recommended, and it was not recommended even in the previous guideline. However, external laryngeal manipulation is different. And a lot of people do this, including myself, during intubation. You manipulate the thyroid cartilage or the cricoid to move the vocal cords towards your vision, and you make it more easy to visualize the vocal cord. That's okay to do. That's different than the cricoid pressure. So continue to do that if you needed to. Atropine is another thing. Atropine pre-treatment prior intubation in the guideline is still there. It says you can still consider it in the pediatric population below 8-year-old of age. However, personally, I don't do it. I don't see the need to do it. Maybe in a very small unit, I might consider it, but I usually intubate without giving atropine. If you are somebody who is doing that, it's not against the guideline. The guideline still recommend it, and it says it's reasonable to do. Interestingly, atropine is the only drug that have a minimal dose. Why? Because atropine, if you give it in a smaller dose, smaller than 0.1 milligram, then you might end up with a paradoxical effect. Atropine usually give you a tachycardia, and we use it in bradycardia or to prevent bradycardia. But if you give a smaller dose, smaller than 0.1 milligram, then you might end up with a paradoxical effect and bradycardia. However, in this guideline, they actually address that. And what they say is the evidence does not support that statement. The minimum dose, there is no minimum dose for atropine. You can give doses less than 0.1, and don't be afraid of the paradoxical effect or the bradycardia-induced atropine. Looking at the capnography, I love the capnography. It's super important. It helps you to confirm your intubation. It also gives you a clue, especially if you are transporting that patient. It gives you a clue if the ET tube is dislodged. So it's highly recommended in the guidelines. Drug therapy, we are talking about a non-shockable rhythm and shockable rhythm, mainly the epinephrine. In the non-shockable rhythm, you should give epinephrine as soon as possible, ideally within 5 minutes, because that improves your ROSC. Does it improve your neurological outcome? No, but it does improve your ROSC and your chance of discharge to the hospital, but does not improve your neurological outcome. Compared to shockable rhythm, electricity takes priority, and then after that, you can give your epinephrine, and you should not delay it as well. Other drugs that we use usually, My colleagues in the ICU always love this. They always give calcium, they always give bicarbonate, but the guidelines do not recommend routine use of these medication. However, there are circumstances where you need to give them, mainly if you are dealing with somebody with suspected hyperkalemia, somebody with hypocalcemia, somebody in the context of calcium channel blockers or hypermagnesemia intoxication, then it's reasonable to give calcium. On the other hand, if you have somebody with severe acidosis or somebody with hyperkalemia, then sodium bicarbonate is reasonable to be given. Talking about energy dosing, the guidelines are still the same. There is no difference in terms of how much you should give. You always start with 2 joule per kilo and you escalate from there. There are interesting statistics showing that energy less than 1.7 milligram joules per kilo are associated with lower survival. Those above 2.5 associated with lower survival. Those in the middle have a higher chance of survival. And I think this is mostly because of a time bias rather than anything else. And again, it's just a single shock, and then you proceed with the CPR. There is no room for dual sequential defibrillation or giving back-to-back shocks without CPR. We discussed antiarrhythmic. It's mainly either lidocaine versus amiodarone. I'm a big fan of amiodarone. I'm so used to it. But actually, the literature does not differentiate the two. There's no differences in terms of the outcome. However, some studies show that lidocaine can increase your survival rate compared to amiodarone in terms of ROSC and survival in the first 24 hours. But then you look at the more important patient-oriented outcome like discharge from the hospital, there's no difference, whether you use lidocaine or you use amiodarone. The only difference here, some of the institutes actually have their own lidocaine in the crash trolley pre-filled. So it will be easier for the nurses to give lidocaine instead of to prepare the amiodarone. But the guidelines does not recommend one over the other. You are free to use any of them. In terms of your resuscitation, we talked about this earlier. Look at your end-tidal CO2 as a marker of a good quality CPR. Aim for end-tidal CO2 between 10 and 20. If you have an ART line in the ICU setup, aim for 25 millimercury for infant. Aim for more than 30 millimercury for children. And if you have a CPR feedback device that they will tell you are doing good compression, be faster, be slower, then you can use those. But do they increase your do they improve the outcome of those patients? The data are very limited. There is no recommendation in terms of they will improve the outcome or not, but for definitely they will improve your quality of your CPR. Point of care echo, it's advisable to use it with caution, not to delay your interrupt your compression, but to help you to identify reversible causes like tension pneumothorax, pericardial effusion, etc. Post-cardiac arrest, we'll talk mainly about temperature management and hemodynamics goal. This after achieving ROSC. There is a big fuss about hypothermia. I remember when the therapeutic hypothermia article released in the past, we were very enthusiastic that when we cool patient down to 32 Celsius degree, they will have a better neurological outcome, which is a very hard, solid outcome in cardiac arrest. And we're very enthusiastic about it. However, latest literature shows that there is not much difference between whether you aim at lower temperature versus preventing fever. So 32-degree versus 37.5, there is no difference. There is no difference in the outcome. Actually, the lower temperature are hard to achieve and they are associated with bad complications like coagulopathy and other stuff. So the guidelines now still gives you the room to do whatever you want. However, it's easier, more feasible to do the normal temperature. In terms of hemodynamic goals, after ROSC, you should achieve 10th percentile of systolic blood pressure for that child and avoid hypotension because hypotension is bad and it will lead to secondary insults. Continue monitoring all the hemodynamics of the patients and treat shock aggressively. So if the patient is hypotensive, you should give him fluid and start inotropes quickly. What about your oxygenation? Avoid hyperoxia and hypoxia. Aim target your SpO2 of 94 to 99%. And then what about your end-tidal CO2 or your PCO2? Then you should aim normocapnia. Actually, there are some studies, emerging studies that shows that targeting mild hypercapnia might be beneficial, but did not reach to the guideline yet. Maybe we'll anticipate this to happen in the next few years when we have more literature supporting it. And why it's bad? Basically, the extreme fluctuation in the PCO2 will affect the cerebral blood flow. Moving on in the cardiac arrest, post-cardiac arrest management, and we'll talk about seizure. Seizure is very frequent in post-cardiac arrest, and it can happen up to 1/3 of the patient. The majority of these seizures are subclinical, non-convulsive, so detecting them is hard, and you need a continuous EEG monitor for all patient post-cardiac arrest, and this is the new guidelines from 2020. And if the patient showed any signs of seizures, you had to treat those seizures aggressively. Should you start anti-epileptic medication prophylactically? The answer is no. And also, we are now moving towards, because of the recovery, we are doing good in terms of recognizing the arrest, managing the cardiac arrest, and post-cardiac arrest. We are looking at the recovery phase more and more, and we need to emphasize on the neurodevelopment of those patients, the physical and the emotional outcome of those patients. Prognostication is beyond emergency medicine, but we'll go through it very quickly for the sake of our colleague in the ICU. What they say in the recommendation, you should avoid early prognostication. Don't depend on a single modality like a Glasgow scale or the presence or the absence of the papillary reflex by themselves. The biomarkers, there's many biomarkers under investigation for prognostication purposes, but none of them actually achieved a result that support utilization, routine utilization in the guidance of prognostication of patient post-cardiac arrest. The guidelines recommend looking at the papillary light reflex. If it is present within the first 12 hours, it's good. If it is absent in the first 12 hours, it doesn't tell you anything. But beyond 48 hours, it's a bad sign. Also, serum lactates. If you have a serum lactate after 12 hours is less than 2, it's a good sign. If you have it higher than 2, it doesn't tell you anything. Some of those have a prognostic positive predictive value, but they don't have a negative predictive value. Same as the head CT. If you do a head CT in the first 24 hours and it was bad, that's a bad outcome. It's a bad prognosis. But it was normal, it doesn't tell you anything. It doesn't say this is a good, the prognosis is good. It doesn't tell you anything. MRI at 72 hours is the gold standard modality in terms of prognostication. It can tell you whether there will be a good outcome or a bad outcome. Same for the seizure and EEG. If you have abnormal EEG in the first 3 days, then it's hinder a poorer outcome. Moving on again, present an interesting topic. I don't know how you guys practice in Saudi Arabia, but in Oman, at least in my emergency department, when we do a lumbar puncture, we actually ask the parent to leave the room. Imagine the presence of family members in the resuscitation of a cardiac arrest child. So the literature actually supports this behavior. They want the family to be present because it gives them the feeling of involvement and also help them as a closure. Also, it helps their psychological well-being. It is associated by studies. It's associated by lower incidence of depression, isolation, post-traumatic stress syndrome, and those families after the arrest or after losing their child. And it's also helping in the grieving process. They will be able to grieve faster. They will have less isolation if they were present in the resuscitation room with the doctor. However, if you looked at the perspective of the physician, including myself, I think this will put us in a lot of stress, a lot of anxiety. The parents are looking at you and watching what you are doing. And there is a fear of litigations. And finally, it's not only okay to leave the parent in the resuscitation room. You need to dedicate a person to stay with those, and that will make your team one man short. So it's the literature recommended. I don't know if it's feasible in our area, at least in my place. I think it will be very difficult to do that, but the evidence recommended, and if you can do it, probably that's a wise thing to do. And I will leave it for you to decide. Recovery and rehabilitation is a very important thing. They highlight it many times in the guidelines, and we should look at this because there are many survivors out of cardiac arrest, and we should take care of them. And this journey is long and require a lot of multidisciplinary teams, and we should also focus on that. I'm reaching to my end of my presentation. We'll briefly discuss the algorithm in bradycardia and narrow complex tachycardia and a wide complex tachycardia. In the bradycardia algorithm, there is no much change, though they mentioned there is no lower limit of the dose of of the atropine. In the algorithm, they did not change it. It's only mentioned between the line. So in the algorithm, there is still mention they still mention there is a minimum dose of 0.1 milligram for atropine. So the algorithm is the same. Look for reversible causes. Hypoxia is the most common reason why kids goes into bradycardia. Hypotension, hypothermia, hypoglycemia, and toxic ingestion and acidosis. Give atropine, and the dose is 0.2 milligram per kilo. There is no minimal dose in the guidelines. However, in the algorithm, they still use it. So I leave it for you to decide. I'll probably stick to zero point 0.1 as the minimum dose. If there is the heart rate goes below 60, which is something that really bothers me in this guideline, as usual, you should start CPR, despite if the patient's still having pulse, but the rate is less than 60, because we think it's not enough to perfuse the body. And then you continue your regular CPR. So cycles of EP and compression every 3 to 5 minutes. Is it better? We don't know. There is no literature that supports CPR and giving epinephrine while hoping that the heart rate goes up. Narrow complex tachycardia, there is new update here. Basically, if the patient is stable, then you should use vagal maneuvers, and they also mention the modified valsalva, which you tilt the bed of the patient so to increase the cardiac the venous return, that have a higher success rate compared to the standard valsalva maneuvers. If the patient is an infant, you can use ice to the face. Don't delay giving adenosine. Prepare yourself for adenosine, because these maneuvers most of the time fail. The dose is exactly the same. The new update here: if you fail the Valsalva maneuver, you failed adenosine and the cardioversion, and you don't have a cardiologist, then you can try to give IV Satalol. IV Satalol is there now in the guidelines, and you can give it without discussing it with the cardiologist if you don't have a cardiologist. But if you have a cardiologist, you better call the cardiologist to take that decision. If the patient is unstable, then you always go with electricity. You don't need to sedate the patient if that will waste the time. If you have the time and the means to do it, then feel free to do that. Wide complex tachycardia, I love this a little bit because they explicitly talked about if you talk most of the pediatrician, they always think if you have a wide complex tachycardia, you should give adenosine because that's the treatment. It's not the treatment. It's actually a treatment for SVT, but that mimics VTAC by having an aberrancy, either baseline left bundle branch block or a baseline right bundle branch block or a WBW. So if in that context, you are not sure if this is a VTAC versus an SVT, then feel free to give adenosine as a diagnostic and therapeutic. However, be very, very cautious if the rhythm is irregular, and that's very difficult to notice if you have a very fast heart rate, then there's more chance that the child is having a WBW and atrial fibrillation. And if you give adenosine, that's a super harmful, and you can push the patient into cardiac arrest and ventricular fibrillation. There is a lot of teaching podcasts and videos about this, feel free to YouTube it. Quick summary about BLS updates. The sequence is still with the CAB. If you have a foreign body, then start with the blows to the back. And if there's an ancient infant, then you do a chest thrust. Compression technique, the two fingers are out. You stick with encirculating the patient and doing two thumbs technique. And or you can use your one hand or two hand on the compression. The quality of CPR is still the same, no changes. The defibrillation is still the same, no changes out there. The pulse, again, airway, if you can ventilate, no rush to intubate. Cuff tube, slightly better because they have advantage. Capnography is super important, no cricoid pressure. But you can still manipulate the airway by using external carotid, external thyroid cartilage manipulation. Drug therapy, give epinephrine as soon as possible. Energy is still the same, no differences is there. And there are some physiological target if you are in the ICU setup in diastolic blood pressures. And if you have an end-tidal CO2, we are still having the same targets for compressions. And then also, when you achieve risk, there is a hint from the end-tidal CO2 where the end-tidal CO2 can shoot. The guidelines always emphasize on quality improvement and training, debriefing as a cornerstone of improvement. So immediately after the event, cold debriefing is you do it the next day. Simulation is where we can improve and learn in a safe and safe environment. CPR feedback at the same time, whether you have if you have a device or you have a coach. Always have a coach to monitor your quality of CPR because good quality CPR is the cornerstone of resuscitation of a cardiac arrest patient. System of care is super important to recognize early management of those high-risk patients and make sure that we are sticking to the guidelines and we have clear protocols in our institution. I will leave these 10 high-yield take-home messages. You can read them later on in your free time. And I will give you a QR code. Feel free to scan the QR code. It will allow you to download a PDF version of my slides. But before you download them, I would like to hear your feedback. If you have any questions, you can also send me questions through the same link in the QR code. And I was very happy to be here today. And if you have any questions, please feel free. This is the end of my presentation.
Thank you, Dr. Sufyan, for the really great and very comprehensive presentation about the resuscitation 2025. You summarize it very nicely through your presentation. You take us from early recognition of arrest and immediate high-quality CPR to be deployed. Along with that, you ended with the post-cardiac arrest care and the hemodynamic support that needed. There is one question from the audience. Up to which part of the face you would cover with ice pack? Forehead versus forehead plus nose sparing the mouth. He's asking about the vagal maneuver of the SVT.
So the recommendation is actually the nasal bridge. The nasal bridge. So your forehead and the nasal bridge, I will do it. But the thing that I would never do this because I can't find an ice in my shop. And always Valzava maneuver, they always fail with me. So don't waste your time. Don't run for the ice. Prepare yourself to give adenosine. Adenosine is the way to go. If the child is a bigger child, maybe Valzava has a higher chance of survival. We don't see much of that in neonate cardiac arrest or infant cardiac arrest. I don't know what the experience of the people in the Zoom, but in general, I think it can. If you have an ice, then go for it.
Yeah, okay, that's perfect. I have one question from my side. So, what is the single most practice changing update in 2025 in PALS and as well as in BLS guidelines that us as a frontliners ED must implement immediately among the updates that has
Okay.
been
I
changes?
think I think, as I said at the beginning of this of my talk, don't expect a major change that will change the way we practice, because these guideline has been there for the past, I don't know, since the 90s, and we are doing these update every 4 years, and we reach a stage where we no longer have a new things to do. However, I want to say one thing is probably that removing the two finger technique on compression was a
Yeah.
very good idea, because I could see lots of people doing this two finger technique, and this was a use this technique. And if you are using it, you should stop doing this. This was the major thing happen. The rest of the things, I don't think they are changing the how we practice, except if you are using the two finger techniques. So the answer is just get rid of the two finger technique in your compression. The rest is actually we are doing what we are doing right. The most of the things we do, the guidelines say we already implemented it. It was there since 2020. There's no major change in there. Just continue to do what you do.
Yeah, okay, amazing. And I can't emphasize more about the two finger technique, which is, I love it in the new update. Another question from Dr. Tamer. Thanks for your nice presentation. Is there a cut point of time regarding when to declare the patient and stop CPR after 15 minutes or 20 minutes or 30 minutes?
Beautiful question. This question get asked all the time.
Yeah.
The answer is we don't know. Really, we don't know. There is no right answer in here. What they say, they also try to see if you have a, let's say, a pH or a potassium where you need to stop the resuscitation. There is nothing in the literature that can tells you at this X amount of minute or X amount of lab value, you stop resuscitation. But we are dealing with kids, and we have parents who are very hopeless at that moment. We never stop. Personally, even if the patient comes in with signs of rigor mortis, I'll probably do a CPR for the sake of the parents. But to answer your questions, literally there is no, there is no number that you need to look for. Personally, I would go for 30 minutes maximum. If
Yeah.
there is no shockable rhythm, there is no differences. So if you are doing CPR and then you went from systole to VTAC, then probably I will give him more time. I will do longer CPR. But if I did a CPR for 30 minutes and it was always systole or it was always PEA, I will stop at around 30 minutes. That's my number. But you can stop earlier. You can stop at 20 minutes if you feel comfortable. But for me, the number in my head is 30 minutes. And it can be extended if either I see a change in the rhythm, especially a shockable rhythm, or the patient revived and then he went back to in a cardiac arrest. Then I will definitely try more harder and longer, even up to 60 minutes. I have done CPR for an hour before. So if that's the case, for sure we'll push harder, because that's the only hope we have, and we have parents that depend on us, that are helpful, hopeless. So I think doing our best to try to bring those patients back, but at the same time keep in mind the longer the cardiac arrest, the outcome could be really bad, because this patient probably will never be the same. The neurological outcome is very poor, so it's a give and take. There is people who advocate to do everything, and people who say, you know what, the outcome is really bad, I stop now. And keep in mind, if you are working in the emergency room, you should not put all your effort in one patient for 60 minutes. You are doing CPR while you have a full department full of patients, because the next ticking bomb can be waiting outside for you.
I can't agree more. Actually, it's a personal thing. And from my side, I'm actually doing it over 20 to 25 minutes. However, I can extend it as per Dr. Sufyan said, and we can exclude the drowning for sure patients that we can go for longer than 1 hour or 2 hours based on their body temperature. From there, we can go. There's one last question by Dr. Samah. Thank you for the balanced comparison. In settings like ours, where family dynamics and cultural expectations are strong, should family presence during resuscitation remain dependent on individual consultant comfort, or should it be standardized institutional competency?
Very excellent questions. And again, you have to keep in mind these guidelines does not take into consideration the cultural background, the area we are living here in the region. And I assume in Saudi Arabia, you face the same challenges here based on the community culture. And I think it's a bit hard, really hard to have family members into the resuscitation room. I would love to have that. but I think it will be more disturbing to the team because I have seen parents pulling doctors, do your best, do that, pushing doctors. So that can affect your actually your delivery of care. So if that's the case, you should not do it. I will say don't. This is not something you can make it as a protocol or an institutionalized. It should be dependent on you and the circumstances. If you see this is, for example, and I will give you an example that could happen. Let's say the father is a medical healthcare worker who is aware about how we work. I don't think I will kick him out of the room. I will let him be available there. It's okay to keep him in the room because he understands how we work. But on the other hand, somebody who's have no clue how system work, what is the role, what is how we resuscitate, it can be very difficult to keep him in that room because probably that will be, though the evidence in the Western countries shows that will decrease their anxiety, you don't know what will happen to the patient in our, like the parent in our culture. Maybe they will be very anxious about it. They will have their post stress PTSD after the events. So that's, we should not extrapolate everything happening in the West to the East. I would say just keep it as the individualized and consultant comfort as well as the parent, because you can tell if you see the parent who are like solid, they can handle being in the room, then probably you can allow it. But if you see they cannot, then I think it's better to leave them outside the resuscitation room.
No, okay, Dr. Sufyan. I think, yani, I agree to disagree for that, because I personally, when I put the parents in front, or let's say within the room, while I was the team leader in resuscitation, I found it different when you break down for them the bad news. It will be
Yeah.
easier for them to, let's say, absorb it and take it very smoothly when they see the extra effort that you are putting in their kid at that time of resuscitation. However, on the other hand, some of people they are not easier to absorb such situations as you mentioned. So I think it's a case by case. However, if we tried our best to keep them within the rooms, I think it will be really better to see their kids in their last minutes, along with that to see our efforts that we are giving during resuscitation. Another question by Dr. Amir. Is time of CPR varies with comorbidity?
So probably yes, because sometimes the outcome is really poor. Probably our time of CPR will be shorter. Let's say this is a patient who are maybe meant to be a DNR because he has a very complex background and then he arrested before the final decision. Probably my CPR will not be long because the comorbidities, I know the outcome of this. Even if he survived the CPR, the cardiac arrest, the outcome is still poor based on comorbidities. So probably I will have a shorter time. I will not do a CPR for 1 hour of a child who has let's say, terminal cancer.
Can't agree more. I think we came up for the last of our session. Thank you, Dr. Safia, for your time, and thank you for giving us. This is a nicely and amazing presentation that summarized the pulse and as well as the BLS. And inshallah, we'll see you all after Ramadan with our next speaker. Thank you, Dr. Safia, for your time.
Thank you for the opportunity. I'm really happy that we did this, and I'm looking forward for the next speaks.
Inshallah.
Thank you.
Thank you so much.